Dr. Alois Kamuragie, Mrs. Andrea Grosvenor, Mrs. Karima Akins-Mitchell, Dr. Evangeline Springer, participants. Good morning and welcome to this workshop. I am Barbara Carby, the Director of the Disaster Risk Reduction Center of the Institute of Sustainable Development at the University of the West Indies. So I will just give you a little background to the project which has brought us here this morning. Now, as those of us in disaster risk management and who have been involved in responses over the years know, psychosocial support interventions have been taking place for many years. Indeed, teams have been deployed in the past to provide psychosocial support to affected countries. The need for psychosocial interventions was reinforced in 2017, that very bad hurricane season we had with the 2 Category 5 storms that came through. And it was unanimous in all the debriefs after that season that there was a need to increase capacity in psychosocial support. Psychosocial support teams were not originally part of the response mechanism. Now, UNICEF, recognizing this gap, kindly provided funding to the University of the West Indies for a project called Enhancing and Integrating Psychosocial Support into the Regional Response Mechanism. This project had 2 major outputs. You have to mute. One was a skills inventory, which is a database with volunteers who will be deployed after an event to give psychosocial support in affected countries. Now, these volunteers, of course, are all trained and qualified persons in the field. A second output were the standard operating procedures for integrating the psychosocial support teams formally into the regional response mechanism, which is coordinated by CDEMA, the Caribbean Disaster Emergency Management Agency. Now, this workshop introduces the psychosocial support team to these procedures. I would like to recognize the important contribution of UNICEF to the effort and to thank them for so kindly providing the funding support which made the project possible. Another UWI partner is CDEMA, the organization, as I said, which coordinates response across the CARICOM states and which manages the regional response mechanism. CDEMA is an important partner here for several reasons. One of the main ones being that CDEMA will be a key resource for sustaining the project outcomes over time. And the database and the procedures will actually be handed over to CDEMA at the end of the project. We have heard that the regional response mechanism is an important structure into which the psychosocial support team will fit during a response. Here to tell us more about the regional response mechanism is Captain Robert Harewood, who is the Senior Program Officer for Preparedness at CDEMA.
Okay, so you had a quick peek into my next slide. So the next slide really just gives an introduction to CDEMA. CDEMA was established back in 2001 as the Caribbean Disaster Emergency Response Agency, or CDERA. And this was as a result, on the request of the governments of the CARICOM community or CARICOM. Um, and CDEMA was or is the regional agency to provide that guidance and oversight of disaster management in the Caribbean or for disaster management in the Caribbean. The organization was established on principles of intergovernmental cooperation and addressing disaster risk management. As an organization, we transitioned to CDEMA on September 1st, 2009, and we operate under a comprehensive disaster management or CDM framework in collaboration with several stakeholders, including national disaster offices, non-governmental organizations, community-based organizations, academia, as well as developmental partners and the private sector. CDEMA was established under the Articles of Agreement, and there are 43 articles under the agreement, so I wouldn't go through all of them here. But just to note that several of the articles were designed to facilitate cooperation amongst various entities for response. And in particular, Article 13, which now has 16 or present 16 functions for the coordinating unit. The Article 13 establishes the coordinating unit, and the coordinating unit is the sort of the headquarters, if you will, of CDEMA, and we focus primarily on preparedness and response, information management, providing disaster loss reduction and strengthening comprehensive disaster management capacities of states. And one of those functions includes the ability to mobilize and organize technical assistance from interested national and international bodies to assist in the development of disaster response capabilities of participating states. This is our mandate. And the third point is to mobilize and coordinate disaster relief for governmental and non-governmental organizations of affected participating states. And our philosophy, mission, and vision statements. And our master strategy is that we will cultivate strategic partnerships which build national and regional capacity for comprehensive disaster management. This is what our organizational chart looks like. So at the top, there is the CDEMA Council, which is the Council of Ministers. And this council states those ministers in CARICOM states that are responsible for disaster management or national security. Then the Technical Advisory Committee. This is made up of the national disaster coordinators. Then at the coordinating unit where we sit, we're headed by an executive director. There are two program streams at the coordinating unit. One falls directly under the office of the executive director, which includes ICT, human resources, planning and business development and finance. And under the deputy executive director, there's the technical program management division, which includes preparedness and response and communications and education department. So the CDEMA mechanism is made up of now 19 participating states, and we are all small island states with high vulnerabilities and varying individual capacities. And I know earlier we are the champion for comprehensive disaster management. So what is comprehensive disaster management? We'll come to that in a couple of slides. Participating states are, you can see in this particular slide, stretch from Guyana, Suriname, South American mainland, to as far north as the Bahamas archipelago to include Turks and Caicos Islands, and over to the west, Belize, and as far east, most easterly island in the chain is Barbados. So there are 19 states. So how do we manage or coordinate amongst these 19 states? So the agreement also calls for or requires us to have sub-regional focal points or SRFPs, as they are affectionately known. So the region is divided into 4 sub-regions. And these sub-regions are designed to support within their catchment area any participating state that may be impacted by a significant hazard or a disaster event. So the sub-regions include within the northwestern sub-region, which is led by Jamaica. And in each sub-region, there's a sub-regional focal point. And the focal point in the northwestern subregion is Jamaica, and they include Belize, Bahamas, Haiti, Turks and Caicos, and now Cayman. I must apologize for not updating that. And the eastern subregion includes, which is headed by Antigua Barbuda. They include Anguilla, Montserrat, St. Kitts and Nevis, and the British Virgin Islands. The southern subregion, led by Trinidad and Tobago, includes Grenada, Guyana, Suriname, and the central subregion, which is led by Barbados, includes Dominica, St. Lucia, St. Vincent, and the Grenadines. Now, when we say led by a sub-regional focal point, the sub-regional focal points were really determined by the capacity of that country to render support to to within the catchment area. So the sub-regional focal points all have standing militaries with significant capacity to render support to an impacted state within the sub-region. However, given the way we operate within a region response mechanism, an impacted state um, could be provided with assistance outside, or could and will be provided with assistance outside of the catchment area. So you would note that for the Bahamas, you would have had countries as far as Trinidad rendering support and the like. Um, so although the regional response, the sub-region um, is divided as it is to provide that initial support will be available from across the other participating states and the other regions as well. So as I noted earlier, comprehensive disaster management really speaks to the management of all hazards through all phases of the disaster continuum and by all people, including private sector, public sector, civil society, and the general population. And it looks at risk reduction and the management and integration of vulnerability assessment into the development process. And why is this important? If years ago, people would always ask national disaster offices or inquire as to what they did outside of the hurricane season, because generally many of the processes, actions, SOPs of the past were designed around the hurricane hazard. We've since moved forward leaps and bounds since then. And comprehensive disaster management then looks at all hazards, earthquake hazard, tsunami hazard, drought, um, of course, the hurricane, tropical weather systems, and the myriad of all hazards, including the pandemic type hazard. So CDM is really a shift from being reactive. The disaster office focuses only on uh, individual hazards to a more um, anticipatory shared responsibility. Now we view hazards exposure as an ongoing process. And this now aims to reduce vulnerability across all sectors. So it's no longer the realm of the disaster office alone, but the entire society has to look at CDM and has to engage emergency management and hazard threats. To the regional response mechanism. So the RM, as affectionately known, is designed under a doctrine that um, aims to provide effective and efficient coordination for support to CDEMA, any CDEMA participating state, which requires regional and or international assistance for the response. There are several principles of the RM doctrine, and they include, first of all, respect for sovereignty, regional solidarity, compliance with international humanitarian standards. Those standards include humanity, impartiality, neutrality, and independence, and adherence to the principles of partnerships as well. The RM aims RM is comprised of a number of plans and procedures and guidelines. There's also a group of response units, and we'll talk about them in a second, agencies and organizations, and a collection of agreements, memorandum of understanding, and protocols. So the RM is expansive, and it is executed by the CDEMA coordinating unit on behalf of the CDEMA participating state through the Regional Coordination Center. So this is the conceptual framework of the RM. So on within the center, the RM is there, and on the left, um, there's a governance structure. which includes national plans, regional coordination plans, specialized plans, the development partner groups, set of MOUs, SOPs, acts of parliament, etc. And on the right, this is the regional response units that make up the RRM, which is the CARICOM Disaster Relief Unit, et cetera, et cetera. And we'll go through them individually in a minute. And then we note at the bottom, the sub-regional structure is also identified there. Some of the RRM actors. So the organs of the RRM. Organs include there's a regional coordination plan which supports activates and manages the entire system. The regional coordination center, telecommunications plan, the Caribbean Development Partners Group, and these are coordinated within the jurisdictions of the UN resident coordinators. And these groups, we'll come back to them in a minute, but these groups are found in Trinidad and Tobago, which the UNRC, Suriname, and that group or grouping looks after Suriname, Aruba, Curacao, and St. Martin. But for us in the CDEMA states, it will be Trinidad and Tobago and Suriname. Barbados, the OECS, the grouping includes Barbados and the OECS. The RC in Belize, well, she treats the Belize and El Salvador, but for us, it would just be Belize. And the RC in Jamaica, this regional coordinator, they look after Jamaica, Bahamas, Bermuda, Cayman Islands, and Turks and Caicos. Not to forget the regional coordinator um, in the UN regional coordinator in Guyana as well. We come back to these again. Further, there are also the national disaster plans, the specialized plans, and regional warehouses, MOUs, etc. And then the response teams. Response teams are made up of the Rapid Needs Assessment Team, or the RNAT, the CARICOM Disaster Relief Unit, or CDRU, Regional Urban Search and Rescue Team. This is a light level team. CARICOM Operator Support Team, or COST, CARICOM Damage Assessment and Coordination, or CDAC team, and technical support teams, which to be led by CMA, the Caribbean Institute of Meteorology and Hydrology, CARILEC, Caribbean Wastewater Association, and many others. The regional coordination plan, it guides the operations of the CDEMA system during the response phase. As you know, it's comprised of several hazard-specific plans, includes a guide for activation, triggering the mechanism, um, includes the regional coordination center SOPs as well, and is a key component of the regional response mechanism. The Regional Coordination Center, this is the central focal point of the CDEMA response. It is located in Barbados, um, but it can be moved, and we have been able to test the movement, the move of the RCC to Trinidad during Trade Winds Exercise 2017. So we know that the RCC can be moved out of Barbados and established somewhere else to support the mechanism. It is staffed by um, RCC SOPs, where it is managed by, guided by SOPs and staffed by person from within the CDEMA CU, as well as volunteers. There's a Caribbean Development Partner Group. This group is established to provide a forum for information sharing between the region development partners and the disaster management institutions. There's really a coordination between the UN system and the CDEMA system. And as I noted earlier, there are five CDPGs, and they are co-chaired all by the UN resident coordinator for that grouping, as well as the executive director of CDEMA. Then there's the Rapid Needs and Assessment Team, the RNAT. This is actually an organ of the CDPG. It is deployed under that mechanism, and it seeks to provide initial independent verification of an impact. Um, and it is set up to provide critical information within a 72-hour period in order for the partners to be able to prioritize response needs and relief needs, etc. The RNAT like the other teams, are activated when an impact on the participating state is imminent, but they only deployed on request of a participating state. Uh, they say a picture paints 1,000 words, so I just want to leave you with some pictures of our deployment after Hurricane Joaquin in Bahamas and Irma in BVI. So the CARICOM Disaster Relief Unit, CDRU, this is a unit which comprises of disciplined forces, the military, police, and fire, and they're drawn from the 19 participants. Well, um, I should say not all 90, 80 participating states. Um, that should really be 90 participating states. Apologies for not changing this slide as well. The unit is deployed to provide uh, humanitarian assistance, HADR assistance to or in direct support of the civil authorities. Tasks include management of relief supplies, emergency communications, and the provision of appropriate personnel for lifeline communications response to, well, essentially, this unit is deployed to provide initially the the type of logistics relief support that a country may require. However, given the expertise that is normally within this unit, they can often or they are oftentimes requested to provide other assistance. So the CDRU is comprised as follows, and given that they would have um, communication experts, they would have a doctor on board, they would have engineers and stuff on board. Oftentimes, the unit is also asked to provide support in other areas for an impacted state than generally is their direct scope. And the unit does appreciate that it has the authority to do so. Again, would leave us with some of the pictures of the CDRU in operations. This the left two pictures on the left are the operations in Haiti after the earthquake. And then we also see those on the right. These are from the BVI after Hurricane Irma, the operation there. This is just some CDRU training that took place in either, well, in Barbados and the US Virgin Islands. The regional security system is also mentioned here because the RSS does provide that critical link between the CDEMA mechanism, the CDEMA coordinator unit, and the discipline forces. So RSS coordinates the CDRU logistics and the movement to an impacted state for us, and they even provide oftentimes the transport requirements through their C-26 aircraft or via one of the offshore patrol vessels, either from Barbados or one of the other RSS island states. That is the CARICOM Operation Support Team, or COS. Again, providing direct support to a country, but the COS provides support to the EOC, or the National Emergency Operations Center, or the the Submarine Emergency Operations Center, or the operating centers on sister islands for those countries that do have sister islands, to lend that or to bring that surge to the limited capacity they're appreciating. When a country is impacted, the human resource is what is impacted the most. And hence why I noted earlier about the concern of pre-deployment to an impacted state. So noting that those persons that are expected to operate in the EOC may themselves be impacted, the COS team is deployed to assist with the management of the operations there. However, once COS teams are deployed, they do deploy into the mechanism that is there and to support the mechanism. The COS team would not go in and, for example, take over any EOC management and the like. These are pictures of the COS team deployed following Hurricane Dorian's impact on the Bahamas 2019. And for the first time, we also deployed a logistics team to support the logistics management and logistics coordination there as well. The damage assessment and coordination team, again, to provide that surge capacity to support damage assessment within an impacted participating state. Same deployment principles as the others. They're deployed on request from the impacted state, and they do go in to fit into the already established mechanism, using either, if the country does not have an established damage assessment process, then they would use the CDEMA process to support damage assessment needs analysis in an impacted state. Regional Search and Rescue Team, or the RSART. These teams are certified in INSRAG, International Search and Rescue Advisory Group um, methods, and they provide a search and rescue surge to the CDEMA participating states. They are deployed through the Caribbean Association of Fire Chiefs, and again, this is done on request of an impacted state. The two pictures you see there are pictures of training with the region security system, as well as waterborne training done in Suriname some years ago. Noting here as well, RSS training, um, night training, as well as search and rescue training done in Antigua in 2013. The team would have been deployed to Dominica post Tropical Storm Erica back in 2015. And these are some pictures that captured the deployment and the good work that they did there. And then there's the Regional Coordination Center. And as I noted earlier, this is the central focal point within the CDEMA response system, that manages the responders, manages everything that has to do with response. So the RCC would coordinate movements, ticketing, billeting, the preparation of food, etc., for those teams that have to be deployed. And it's even a bit more challenging now in the sense that now we are dealing with the coronavirus pandemic. And I'll talk about that just before we end this presentation. Organization chart of the RCC. Again, using the incident command system, there are several cells, operation cells, logistic cells, etc., set up within the RCC to provide that coordination for the respective entities in the deployment. So as relates our response philosophy, we're directed by the type and the magnitude of the emergency, and our capacity and the state's capacity to respond to it. So, and out of or to engage RM, we have to engage all 19 participating states. So there are three tiers or three levels to um, the response. Countries may be impacted such that they can present a level one impact, which is the impact was not significant and there is no external assistance required. And at that stage, we would just the CDEMA system, the CDEMA CU, sorry, would um, just take note and provide situation updates and the like. A level two impact is where it is not significant too, but there's some external assistance that may be required. And a level three is where the event overwhelms the capacity of an affected state and they require external assistance. So you can see for level one, the CDEMA will monitor and share information. And at level two, CDEMA provides technical assistance, specialized equipment, support personnel, and also provide engage in information sharing. And in level three, where the RM is activated on request of the impacted state to provide that the surge capacities required of the state. Some of the responses, early responses of the RRM. No, Lenny back in 99 to St. Lucia, Thomas in 2010. We also have Joaquin, Erica, Matthew, Irma, Maria, and last but by no means least, Dorian in 2019. So with respect to the mission cycle, um, and this would support what your what I would well I must say one of my expectations to this or from this meeting is to see the launch of a new RM actor or response team in uh, psychological support with psychosocial professionals to aid and support HADR, humanitarian assistance, disaster relief or response within the CARICOM mechanism. So having said that, within the operation cycle, we know there's a pre-mission where we engage in preparedness and response actions. On arrival, plan of action, and then we execute our actions. And the mission ends, we hand over, we do our debrief, and then we exit and hope never to be operational again. With respect to COVID-19, the deployment cycle, um, we know that CDEMA's policy is to ensure that no harm, inclusive of any infections, come to any deployed person or um, any person that or any person within the country that you go to support. So when we look at travel, we have to coordinate with the national disaster offices and the participating states protocols for entry as it relates to the COVID-19 pandemic. Entry and then re-entry to descending states or as it relates to descending states protocol. One step that we note is the ability for self-sufficiency. We can provide remote support from experts. So maybe even for psychosocial support, given the pandemic, we may be able to also discuss the use of the technology to provide those interventions required. When we speak to permission, there are some considerations for permission, noting that um, depending on the impact of the state, PCR testing may be required, outfitting of PPE, quarantine requirements, etc. And there's something that I want to say at the end of this, where you're on mission, noting that you are deployed in a hazard environment, whether, but this one we're talking about COVID-19, but outside of this, all hazard environments present particular personal hazards to the individual. We have to note those and dress and operate appropriately to avoid being impacted by them. At the end of mission redeployment, we may also have to do a PCR test on the way back into the the sending state, etc. Just the key points to note: all response teams shall plug into the National Disaster Management System and function within the limits of its authority, respecting the sovereignty of the state. Their roles are to provide surge capacity to the impacted state within their sphere of expertise. Deployed teams should not be an additional burden to an impacted state, and impacted states are responsible for taking or tasking, or giving directives to deployed response units through their NEOC's National Emergency Operations Centers. So these points are critical, and what I also want to note here is, so we are in a COVID-19 pandemic. I almost said season. Um, we are impacted by COVID-19 pandemic. I don't even know if to say we are in a phase one or phase two or phase three of the impact. What we do know is that it is a hazard. If we go to, let's look, for example, at the Dominica scenario, 2017, or Bahamas, Haiti 2010, 2016, etc., or even 2019 with Abaco and Graham Harbor being impacted. If we superimpose the pandemic on those situations, some of the considerations that we may have to come up with would be, um, do we deploy, or would the deployment require quarantine interstate to a state that is already impacted, a state that is impacted and is unable to manage its quote unquote own affairs? Would they be quarantined? If not, then what? Um, Once we go into state and if you look at Dominica, for example, in the 2017 and 2017, and even after Erica, a lot of systems were down. If quarantine centers, etc., are impacted, and we are deployed, and the same way as you are now part of the RRM, and we are deployed, what are some of the considerations that you would have to be mindful of being deployed under COVID-19 pandemic with knock-on effects or with other effects that may be more severe, quote unquote, than the pandemic in some people's lives. And I just say this for just for us to sit at our leisure and think about some of the the conditions under which we may have to be deployed, particularly over the next year or year and a half or 2 years, if the pandemic is still with us. Because the systems, if for example a country is devastated, um, and we are deployed to that particular that country, then what would we be considering? What would we have to note to be able to do our jobs effectively, particularly for psychosocial support? Excuse me, personnel who interact almost one on one with impacted persons. So I close here and open the floor for any questions, and then get a little drink of water at the same time. Over. Are you still hearing me?
Yes. Um, Thank you, Captain Harewood. It's a very comprehensive presentation. Are there any comments or questions? Participants, if they raise their hands, I can see. Just you can raise your hands. We are monitoring the participant list. Slide down for me so I can see the ones at the bottom. Okay. Okay. And Andrea?
Yeah, thank you for this excellent presentation. It's really interesting to see all the work that CDEMA is doing. I was not aware of CDEMA. I heard it recently from the colleagues of CANPA, and I'm really impressed with all the work in a region that really needs this kind of responses. My question is more related to the integration of mental health and psychosocial support, especially in the preparedness phase, and if there are any considerations relating to this for staff and volunteers that are being deployed. Is there any standards or requirements that the staff and volunteers should have, or trainings that they should be doing before being deployed? Thank you.
Okay, thank you for that. Um, Regarding the regional response mechanisms, well, the and I'm going to use this term loosely, the type of individual, type of person, normally it's part of the regional response mechanism. We request or we require that the person um, is quote unquote physically fit. They must have, well, certainly for your type of intervention, they must be trained and qualified to provide that type of intervention. They must be able to be deployed either um, well within the particular time frame. um, and there's several others that all are not coming to mind right now, but there's several others for the deployment within the deployment criteria for an individual or teams under the RRM. But when it comes to your training, um, given that you are a specialty uh, organization or organization of specialists, professional specialists, I would anticipate that your ongoing training would be designed under the auspices of the organization, um, and we would then render the additional support to you with respect to what is required as part of the regional response mechanism. For example, if you look at the search and rescue team, the search and rescue teams, they are teams of professionals in the search and rescue arena. So CDEMA, we would not teach search and rescue. What we would do is provide, if we do provide search and rescue training, we provide search and rescue, we coordinate the search and rescue training using the INSRAG certified operatives, teachers, etc., um, to boost the amount of search and rescue operatives that are available. So maybe going forward, we can also support in psychosocial training, or collaborating and putting together psychosocial training using you all as the professionals to teach that training. I would say that for some time the CDRU, CARICOM Disaster Youth Unit, part of their training did include psychosocial support. I'm not sure if I answered your question. Over.
Yes, I would say partially yes, but I would say that we would really benefit. I mean, the teams that are being deployed, like search and rescue teams, would benefit from some training, like for example, psychological first aid, or other type of community-based psychosocial support when they are in contact with communities of people affected by disasters. And these people do not have to be mental health specialists; it could be anyone. And that is the aim of integrating
Right.
MHP
Okay.
uh,
So
by the community.
what I'm actually saying, without speaking, hopefully not speaking out of turn, because I'm not sure what the future training arrangements will be. But what I'm actually saying is our collaboration with you, your organization, to provide and support various types of emergency management training, even collaborative training. So, for example, when the let's say, for example, there's the trade winds, the regional trade winds exercise next year. It will be taking place in Barbados. Hopefully, Corona will be gone by then, and we can have more face-to-face interventions. But to have organizations such as yours involved in that exercise as well, so you can practice your skills on persons who are actually being deployed, or are exercising in the deployments. Over.
Yeah, that would be excellent. And of course, the regional office and also other organizations like CANPA, I think would be. I'm not talking in their behalf, but from what I've heard, they have a real. And there are representatives here, Dr. Weller and Dr. Bernard could also speak to that. That there could be collaboration to increase capacities of staff to be deployed in terms of PSS. And yeah, we are always open and looking forward to new collaborations and to support in any way possible. Thank you.
Thank you for the question.
All right. Thank you. Peter Weller, please go ahead.
Yes, good afternoon, everybody. Andrea, thanks for raising that point, and Captain Yearwood, an excellent and comprehensive presentation. Of course, CANPA, and I'll speak, I know my president and vice president are here, but as co-chair of the Disaster and the Mental Health Committee, there are some issues here I just want to highlight. Captain Yearwood, you mentioned, I think you said physical or medical fitness. But I think that one of the points that Andrea is raising is the self-care and the mental health of all those who are being deployed. The extent to which they are provided with tips, skills, and assessment of the needs of their own mental wellness. And I think this is a critical component that we can collaborate on. When you're being prepared for deployment,
I've lost the sound.
Yes, so have I. Peter, can you hear us?
is it sound gone?
I
Oh,
think he
you're
dropped
back now.
out
You're
again.
back.
Oh,
You're back.
okay.
All right, yes, I've been dropped off a couple of times, so I'm glad. Okay, so I'm here. I'll speak quickly before I drop again. Psychological support for individuals who are going to be deployed raises a number of issues. one, who is doing the psychological assessment and support, and what are their credentials and certification? Two, how do you assess the needs of those who are being deployed? They don't have to be psychosocial providers, as they can be search and rescue, and they can be whatever. They all are going into stressful situations, and how can they be helped to prepare for managing that stress? So there's that level of development that we can all participate in. But then there's the issue of, again, as Andrea mentioned, when whatever the deployment is, it's going to involve engagement with the people in the communities, etc. And that is where basic psychological first aid skills, the look, the listen, the link referral process can be very helpful and doesn't require any specialty training in psychosocial services or having to be a professional. So again, here is another opportunity that Red Cross or CANPOR, any of the other agencies that do this kind of training could be part of your ongoing work. So it's good to think of perhaps planning for trade winds next year, etc. A quick question though, who provides this kind of psychological assessment before deployment and debriefing currently with CDEMA? How is that being structured?
We do have an organization. I don't remember the name. It is not Network Services. I don't think it is. I honestly don't remember the name of the organization, but there's an organization that does come to provide that pre and post deployment psychosocial intervention to the teams that are leaving out of Barbados, and this is one of the challenges.
Right.
Which is why camp is so important, because you're regionally based. But as it is at present, if a team members are being deployed from one of the, let's say, out of St. Lucia, etc., that team member, he or she may not go through the same pre and post intervention that team members out of Barbados may go through. But that is not even why sometimes I see as the challenge, because I know the teams that were being deployed to Haiti, for example, after the impact of the earthquake, there were some things that we were trying to do locally within the region as well to prepare them for the deployment. I know there were some doctors that said you really can't prepare for the deployment until you get there and see what was happening. So we were taking persons to the morgue, for example, to see what a dead body looked like and all these types of things. But then when they got to Haiti, when they were seeing bloated bodies on the side of the road and all these types of things for days and all, etc., that was totally different to the confine and arrangements that were made to prepare them for what they were going to see. So these are some of the things that we have to be mindful of as well, is how do we prepare personnel for something that they've never seen before.
Yes, and I think that's a critical area. Of course, we don't have time to expand on that now, but there are also
but surely we will in the future.
Right, sure. But I'm just saying that there are lessons to be learned.
Yeah.
And a critical part of this process, I think, is going to be to ensure that all the partners, all the stakeholders are involved. Now, you just mentioned an entity in Barbados that has been doing this for a while. Certainly, they will have, besides their own skills and competencies, they will have learned lessons and have guidance that perhaps CANPA and the Red Cross, etc., could benefit from. I mean, we're talking a cross-fertilization thing here. So I think it's really critical that we identify all the existing players and maybe previous players in this field. For example, the organization doing your debriefing in Barbados, and facilitate conversations among us so that we can really make the most of all the lessons learned and the institutional knowledge. I think that is an important part of this coordination and collaboration process, particularly as implications for training.
Agreed. Agreed, sir. It has to be all inclusive. Thank you so very much for the intervention.
Over.
Thank you.
Thank you. We have another raised hand. Josette, Sam?
Right. I just wanted to add to what Captain Herwood was saying in terms and of the question that was initially asked in terms of what is happening in pre-mission training. One of the things, because Peter and both Captain Herwood would talk about lessons learned, is that RSS, which you would have seen in his presentation that responsible for like first responders. For example, the Army recognized that PFA is very important. And so what has happened is that in the protocol, every pre-mission training, which is training before that hurricane season where the soldiers are trained, we have incorporated PFA, where we have seen the importance of that and the fellows coping much better, having that knowledge and that skill set. We would have also gone out and would have also started some training with the Barbados Fire Service. I think about 150 of their men were trained. And one of the things that I know for sure, Captain Yearwood, is that RSS is determined that when they are deploying persons in such situations to always have psychosocial support teams down there during that time. But the thing now is then how then do you incorporate um, in terms of collaboration, a wider subsection of individuals as opposed to who they work with, because right now it is more a military model that occurs.
Thanks, Jose. I just want to note though that when the RSS, yes, you're correct. But when the RSS deploys, they can deploy to support a humanitarian intervention or with either members for that would support, let's say, the CDRU, which is humanitarian, or for example, in the Bahamas last year, it was strictly security. So within the security realm, even in Dominica, within their security realm, they will generally seek to deploy persons with the psychosocial or psychosocial support from persons within the military or the security realm as well, given that they're dealing with either soldiers or police.
Okay.
Whereas when we're treating to populations, to the others, um, the normal non-security personnel, non-security uh, um, um, elements, then this is where the door is open for all to be all inclusive. Um, because you would appreciate that when security personnel deploy, there are certain things that have to remain under the security umbrella. Hence why you would note that Dominica, for example, and even Dorian, where the teams were deployed, security teams were deployed, request was for persons within the security arena to support their psychosocial needs. Over.
Let us join workshop facilitator Karima Akins Mitchell as she tells us a bit about how she went about developing the standard operating procedures.
So at this point in time, I'm just going to give you a brief background on how we came by the development of the protocols. All right, well, Doc would have introduced the project and the background and the collaboration between UNICEF and UE. From my end, as the codified protocols consultant, my project lasted about 3, perhaps 4 months. And there were 2 main outputs. One, an assessment of the integration of psychosocial practitioners in the RRM. By that I mean it examined where we were with integrating psychosocial support in the regional response mechanism. And from that, we moved on to the development of the codified protocols, which I will refer as SOPs, since that is the language that CDEMA uses. Now, Dr. Alois, Ms. Grosvenor, and Dr. Carby spoke to the rationale for the development of the protocols. Now, this was mainly triggered in 2017 because of Hurricanes Irma and Maria that impacted the Eastern Caribbean. And of course, you heard Dr. I'm sorry, I'm speaking it into being, Ms. Grosvenor speak to some of the findings from the review that was undertaken by CDEMA. And one of them explicitly stated that whilst there were psychosocial practitioners on the ground, they were largely uncoordinated. The other rationale is that as it is right now, CDEMA does not have a psychosocial support response team as part of the RRM. And so those two together led to the development of the SOPs as part of the solution to those problems. Now, how did we actually develop the protocols? Well, the first output, which was an assessment of where we were with integrating psychosocial practitioners in the regional response mechanism, was prepared mainly from a literature review. Now, that assessment, together with stakeholder consultations, is what led to the preparation of the protocols. And of course, having prepared the protocols, we're here today providing an orientation of what those look like. Now, we reviewed quite a bit of data. This is just the main ones. We had an in-depth look at CDEMA's mechanisms and policy framework. And this was for a number of reasons. Even though we're trying to create a psychosocial support team, we had to look at the overall sustainability and fit of that team within CDEMA's mechanisms. We also looked at CDEMA's response plans and protocols, because one, we needed to ensure that there was a strong alignment with the terminologies, the jargons, the expectations, and so on that CDEMA has in place for other teams, and also to ensure that the SOPs would have been annexed to a larger document so that we would not have a document that was hanging by itself. We also reviewed literature on psychosocial support and national coordination mechanisms. Again, when these psychosocial support teams are deployed, they're deployed to an affected state. That state needs to have mechanism to receive and integrate these practitioners in their response processes. So we needed to look at how that, for want of a better word, handshake would look. We looked at whether or not there were existing tools and resources that could provide some support to the teams as they were ready to be deployed. We looked at what types of trainings were being conducted now and what additional trainings would have been needed. We also looked at after action reviews, because these would have given some insights as to what the challenges were with psychosocial support deployment, what lessons would have been learned from any particular events, and so on. And then we also looked at not just the AARs, but the post-impact reviews and assessments. So CDEMA had commissioned one. I know UN Women had commissioned one. I think it was UNDP and UNICEF who had other types of post-impact reviews and assessment done, mainly from Hurricanes Irma and Maria. Of course, this is not the sum total of it. We looked at, for example, IASC guidelines. We looked at IFRC documentation as well. So there was vast amount of literature reviewed to help us to figure out where we were as a region with integrating psychosocial support in their response mechanisms. Of course, like I explained, that data was also linked with stakeholders consultation. Now, we did speak to a few persons. CDEMA, of course, we could not have completed this without CDEMA's input. They had to share their vision of the psychosocial support team. We had to get their commitment as well. And they also shared, like I said, vast documents on the regional response mechanism. We spoke to, and I see her here, Dr. Rubain, the BVI crisis prevention team, because we had to understand how countries were already operating on the ground where psychosocial support was concerned. Not only did we speak to that specific mechanism, but we also spoke to national disaster offices. I mean, TCI and BVI acceded to our request. Within TCI itself, We had other members of the National Disaster Management Mechanism who had key roles to play with the provision of psychosocial support, such as social development, Ministry of Education, and Ministry of Health. So we did quite a bit of diagnosis, discussion, what this would look like, on the national mechanism end. We spoke with PAHO, and of course, we spoke with CANPA as well. I mean, in fact, CANPA was one of the first persons out that we spoke to. Let me just remove this that's blocking me. Yui, Ayodele, Gina, Dr. Edwards, and hope I'm remembering all. But we did speak to quite a bit of persons in gathering information towards the preparation of the protocols. Now, what were we probing when we actually consulted these stakeholders? One, what policy level documents and plans exist? Because as an SOP, it is always annexed to a main document. So we need to get a sense of what these were and how they could be aligned with the SOPs. Who were the stakeholders who were already involved in psychosocial support across the region, some of whom Yvonne in her skills inventory database would have reached out to for expression of interest in participating in such a new mechanism. We were also trying to investigate, as I said before, the link between the regional and national mechanisms, tools and resources, and so on. And also, we did speak with Jamaica Red Cross, because right now we found them very interesting, not just Jamaica Red Cross, but IFRC, because they also have a regional mechanism that they deploy their Red Cross volunteers through. So we wanted to look at, what we could learn from that and whether or not they would be interested as well in participating in this regional approach through CDEMA. So once the protocols were prepared, there was a review process that involved first and foremost the internal project team. That's Dr. Kirby and her team providing that review. Then the document was again sent to the regional steering committee and other external stakeholders. And then once that feedback was received, the document was finalized. Now, the document, even though the terms of reference asks for standard operating procedures or codified protocols, you will find that for the purpose of sustainability and a very deep integration in CDEMA's mechanism, that it not only dealt with routine matters such as you're seeing here in part A, scope and purpose, but then there's also another creature, I'm going to say, another coordination mechanism being proposed alongside the SOPs themselves, which are in part C. And just to elaborate on part B of the document, the issue of, or the problems as presented from Hurricane Maria, COVID, the St. Lucia rains, because quite a number of events for those who had previous deployment experience, they didn't just use Irma and Maria. I got a sense of, what generally happens for other events for which they were deployed. The issue of coordination is not necessarily going to be resolved by deploying a psychosocial support team, especially when the landscape had so many active players. And that's one of the things that we found, for example, that second bullet, who were the stakeholders involved and what were they doing? So to solve the coordination problem, we had to bring them together before, and that will be explained a little later on as we go through the detailed training material. So the SOPs, of course, has its authority in the Regional Response Coordination Plan, which is an annex. It's an annex to the Regional Coordination Plan, which CDEMA currently operates, and I'm sure Captain Harewood will speak to this. and also it is aligned to the regional support doctrine. The scope of the initiative, however, was mainly for the Eastern Caribbean, and that is because of the UNICEF trigger. However, we recognize that part of the sustainability scale-up and replication could very well mean expanding it to the other areas of the Caribbean. So though it has its origin in the Eastern Caribbean, the extent and nature of what is being produced can easily be applied to other Caribbean or other participating states, to use CDEMA's terminology. Now, the purpose of the SOPs is to provide a standard set of coordination arrangements that will enable stakeholders to plan, respond to, and recover from psychological trauma. And again, this is something that we're emphasizing. It is not just during the response phase that the document is going to appeal to. We're taking it a bit further because of the need and the challenges that arose for those previous events that were discussed already. Not only will it provide assistance to the affected states, as in the general population, but we can also expect that assistance will be provided to emergency responders. Because as we have seen in the literature, and as I also gathered in the stakeholder consultations, there is need to also focus on the psychological impacts of events on first responders who have been deployed, as well as those who are based at the national level of the affected state. Right, so what are the objectives? We want to establish a psychosocial support coordinating group that has also a set of terms of reference. We want to be able to mobilize and coordinate psychosocial support to responders and affected population in CDEMA participating states through the use of the SOPs. And we also want to move a little further and even go into recovery from psychological impacts, because again, this is something that was brought out strongly in the consultations, that even now, there are persons who have still not recovered from 2017 events, or even events in say, Bahamas, Hurricane Dorian, and so on. So it is one thing to respond as a region, but also how does failure to adequately deal with recovery affect or predisposes other persons' vulnerability for an impending event. And so those are some of the issues, again, that influenced how the document was designed. Again, the target users, we expect that for the SOPs, we're going to have responders, humanitarian actors, mental health and psychosocial practitioners, and coordinating entities use the document. Responders will need to know what resources are available out there to assist them if they have any psychological impacts from any events. So too will humanitarian actors. As you provide assistance to affected population, here's one opportunity that exists, in addition to the response menu, to provide psychosocial support. And also mental health and psychosocial practitioners will also need to know that here lies this opportunity for them to participate as a region, as part of the regional response mechanism. I mean, a lot of volunteers, I know Dr. Weller himself, for example, could give countless stories of his involvement in situations such as these. And also entities that are dealing with generally with response coordination will also need to know that this resource is available through the region. So that's it in a nutshell in terms of how we got to where we are, and generally what you can expect to find in the document having traveled that journey. So this part of it is actually part B of your SOPs. And I must thank Captain
Harewood.
Harewood for, I think I went there with Yearwood, and there are two different persons at the same place. So I paused. My apologies for that. So Harewood for setting that context, because this is exactly what the literature review was about. Understanding what is happening from CDEMA's end and other national level end, ensuring that there's a foundation upon which the SOPs can actually find footing. And so I think two persons or a few persons did mention the preparedness phase. Now, what I'm about to do is to take you through a proposal for that is actually included in the document to look at a coordination mechanism. And so what I'm going to take you through now is to actually enable you to locate that coordination mechanism within CDEMA's bigger structure, explain what that structure is and the roles and functions. Now that mechanism is called CAPSIG. Now this nomenclature may change, but for the purpose of putting forward the conceptual elements of it, we are going to refer to it as a Caribbean Psychosocial Interagency Coordination Group, hence the abbreviation CAPSIG. Now, a few persons did mention that preparedness is going to be key. Now, it is good if we have a psychosocial response team, but the issue of coordination is going to require some amount of planning and coordination from the preparedness phase before we even enter into the response phase. Why? Because tools and resources, methodologies, techniques, what you use in the deployment phase will have to be agreed upon during preparedness. MOUs may be needed, resources, and we talked about them. For example, Peter mentioned, what lessons were learned from previous deployment, from previous briefing, from the PFAs. How can we incorporate that? Now, that is not going to happen during response when you're trying to deploy a set of team to an affected state. That has to have some kind of discussion and agreement before. And that is one of the roles of CAPSIG. It is to coordinate and collaborate. And I understand we have international players in the regional landscape as well. So it's not just for regional and national individuals and organizations, but those persons who we potentially anticipate working within the region. And I know, for example, that CAMPA has members, or its membership extends even beyond Caribbean boundaries. So how do we get them, before we even start talking about deployment and response, to have a discussion and dialogue about strategizing about direction we should be going? So that is the purpose of CAPSIG. Now, for the purpose of institutionalizing this group, CDEMA, it is going to be anchored in CDEMA's Health Sector Subcommittee of the Harmonization Council. And I'm going to explain just a little about this. Now, I've noticed Captain Harewood didn't touch on this part of it, but this is part of CDEMA's governance mechanism for CDM. CDM meaning Comprehensive Disaster Management, and more specifically, the CDM strategy 2014 to 2024. Now, this is a strategic framework, the strategic plan that guides the whole of CDEMA's operation throughout the region. It has outcomes and outputs related to improvement and getting stakeholders involved in strengthening the response process. Now, to give effect to that strategy, what CDEMA has done is to establish a harmonization council, Comprehensive Disaster Management Coordination and Harmonization Council. And that council has, as it stands, 6 subcommittees, one of which focuses on health. Now, given that health, the issue of mental health and psychosocial support is normally part of their broader health and wellness portfolio. it was felt that this would have provided a more appropriate link into CDEMA, one that will encourage sustainability and one that will also be seamless in integrating in CDEMA's mechanism. So CAPSIG will become a subset of this health sector subcommittee. Now, as it is, there's a simple structure proposed, given that it is a subset of the health sector subcommittee. So there's a chair who is proposed as UWI, and I'm saying proposed because even outside of this project, there has to be an approval phase where it is accepted, approved, and appropriately embedded within CDEMA's mechanism. Now, why UWI? Now, CDEMA is a creature of CARICOM, and as a creature of CARICOM, you would want to have a CARICOM institution that is also holding hands with CDEMA and leading the discussion. However, the value of other expertise, other external partners and institutions cannot be ignored. CANPA, which represents a wide cross-section of national societies across the region, is now recommended to co-chair alongside UWI. Now, because of the discussions involved at that level of the interagency group, you're going to need a secretariat to pull together the discussions, so that they provide the normal administrative duties, but also the monitoring, evaluation, and follow-up, putting together documents, protocols, guidelines, that research and so on. So you're going to need that secretariat to support this mechanism. Now, within that group, that interagency group, one person will be nominated as the psychosocial support team response coordinator. And they would be almost like the overseer for the team that is going to be deployed. Now, again, this recognizes that one, there are issues relating to recovery, preparedness, assessments, information sharing, training, and so on, that will need to be dealt with, and that also impacts on the deployment of teams. So this will allow that coordination to happen and treat with the issue of response as well. Now, who are proposed as the members of CAPSIG? Of course, UWI and CANPA. Of course, again, CDEMA, but CARFA also as another regional entity. We have some players within the UN system who have very strong focus on psychosocial support, albeit their target audiences may be a little different, but UNICEF, for example, a strong focus on children. PAHO, from a health perspective from the UN system, we also have NGOs, ADRA, a representative of the responders, and also because they have been implementing psychosocial support. Again, some of this we have been discussing about borrowing some of these lessons. We have the RSS, the chair of the Education Committee of the Harmonization Council, and by extension also the chair of the Financial Subcommittee. And here is why. There is going to be a very, very strong training component, training and education component of sustaining and the psychosocial support team. There are going to be some cross-cutting issues there. So it makes sense to just bring the chair of that committee on board as well as the person in charge of finance, because as Peter mentioned earlier, how will the deployment of the team be financed, especially if you have volunteers who will have to, who are in private practice? Are we asking them to give up their income earning potential to be a part of this team? How do those arrangements work also? We are sure at this point in time that the deployment and those kinds of issues will need some financial backing. UN Women as well, they were very active in 2017 with the deployment of, let me just say, support for not just women, but persons, well, mainly women, but different categories of women. And then you also have a civil society committee of the Harmonization Council. So what we're trying to do is to pull the experts and pull the relevant expertise that are currently in-house. So what we're doing is just really capitalizing on, as I said before, the foundations that exist within CDEMA. Now, what will CAPSIG do? Assessments. Now, one of the most difficult things to have found during the literature review was any kind of assessment that, gave you an indication of the mental health, psychosocial interventions, where needed more help than others, though I know they existed. How can we create a system and mechanism to allow that information to be available for the practitioners, the DRM experts, to tap into without breaching, for example, any privacy issue and so on? How can we begin to be anticipatory? Because, for example, Captain Harewood mentioned that we're moving from reactive to anticipatory. Part of being anticipatory is being able to identify and assess likely scenarios and start operating and building our procedures to respond to those likely scenarios. We do not yet have those kinds of data available. So whether it's geographic or population targets, we do not yet have those available, certainly for access at the regional level to support a psychosocial response. The other thing they will do is to provide regional coordination for mental health. Now, there are several actors, as I explained before, within the region. A lot of what we do in the response phase hinges tremendously on the preparedness phase. So this group is a group that will discuss all of that, so that one, there's perhaps the need for less response because you would have built some amount of capacities as well as if there's a response, it is certainly coordinated and operates like a well-oiled machine. Documenting and sharing best practices, I spoke to that already. Recovery is not an area that is currently receiving attention, certainly not from the regional perspective. And if you do not treat with the current psychological trauma, psychological impacts from current events, then for the next event, it presents itself as a pre-existing condition, making you more vulnerable, less likely to cope when an event faces you. Monitoring and reporting to CDEMA. Now, CDEMA has agreed to take on this portfolio. However, it will need the help from a group such as CAPSIG because its institutional makeup does not permit it to lend day-to-day operational, oversight and so on for this matter. So we expect that CAPSIG will be, how do I put it, closely involved with reporting and helping to monitoring this issue and guiding CDEMA accordingly. Financing, we need all kinds of resources. Of course, like I said, I'm not a PSS practitioner, but from what I have read and from what I have seen, we will need varied resources to assist us in moving and improving the coordination that we seek. So of course, it takes cash to care. Developing project proposals, whether it's partnership strategies, partnerships agreement, conceptual, whatever it is that will allow CDEMA to be able to access and tap into financial resources of others, then CAPSIG also play a role in this. Someone is beckoning? Okay. And then most importantly, to be able to provide psychosocial response. Okay, can I have all persons mute? Please, thank you. Right, so providing a psychosocial response. Now, I'm about to present in the post-launch session what the proposed SOPs for the response look like. This is just the initial phase of that drafting process. Of course, as we begin to think through, as we begin to operationalize and deploy teams, we're going to find that we may need to improve upon, add, remove elements. Again, CAPSIG can help with this. Psychosocial training, which can be very simple, psychological awareness to psychosocial first aid to the very deep science, and some of you are operating at the PhD level. However, coordination of that training can be managed here because we have a number of actors within this regional land space delivering psychosocial training. And so we need to optimize the use of resources. But if we do not know what each other is doing, we're going to trip over each other, and that is tantamount to wasting resources. So if we have that coordination mechanism, certainly for training, it will help in the right direction. Code of conduct. I think somebody asked earlier about what prerequisites would need to be satisfied by a potential person interested in being deployed. Now, there would be a code of conduct. CDEMA has its own set that Captain here would have mentioned, that every response team that is to be deployed has to go through training and orientation in those codes of conduct. But certainly those are general. From a professional point of view, you will also need to look at what codes of conduct will govern the teams that are being deployed. And roster of response personnel. Earlier, Dr. Innes Springer spoke to persons preferring to be deployed for 5 days, 15 days, and so on. From a professional point of view, the team, CAPSIG, will now have to determine what is a maximum that we prefer our teams be deployed for. It could be based on their own readiness and mental state. From a professional point of view, you know, we prefer that they not be deployed, or depending on the magnitude of the event. So you can always develop a roster of personnel to be deployed for any single event. Of course, this is not one standard document, but it's going to be dependent on each event and what comes with it. So we have Yui as chairperson, and as chair, what we expect is that, notice we say UWI, which is a broader institution. UWI must now find within that very complex and resource-rich environment somebody with the ability to lead a diverse stakeholder group, skilled in inclusive coordination processes. This is very important because whether we want to acknowledge it or not, power struggles, power differences, you know, and if you're stubborn like me, who want to have their own way, and it's my way or the highway, you're going to have somebody with those skills who are able to help in navigating that environment. Somebody as well who's very knowledgeable in the discipline. Somebody who's strong in organization, planning, and project management, because the tendency for most organizations is to projectize tasks so that you get them done quickly. So that's another skill that the person will have to come to the table with as well, and to also ensure that there's effective participation and not a matter of who shouts the loudest, you know, in the room, but that all stakeholders are given the opportunity in a democratic way to add their opinion, and that decisions are taken for the benefit of most. Certainly not all. There's hardly a situation where all agree, but certainly for the benefit of most. So the chairperson, of course, would chair meetings, prepare agendas, ensure participation. But then there are other functions, for example, such as reviewing performance, and again, that connection with CDEMA, presenting your findings and recommendations, because again, CDEMA is taking on this portfolio, but it needs help giving it the day-to-day operational attention. And the co-chair, of course, will share those responsibilities and as camper. So mutually, and I think in principle, I think it is safe for me to say that both CDEMA, UWI, and camper has agreed exactly how that relationship will work, but there's certainly some agreement that the three can come together, perhaps further elaborate this, look at what is there and begin to roll out at the soonest time possible. Again, the Secretariat, as I mentioned, you're coordinating meetings and also to ensure that all the undertakings of the discussions of CAPSIG fit within CDEMA's internal procedures. Now, this is in effect going to be a creature of CDEMA's own mechanism. So at all times, the eyes must be held firmly on CDEMA's protocols, guidelines, policies, articles of agreement, and so on. And within that, a person or perhaps one or two persons would be designated as lead, as response coordinator. So there's a day-to-day routine planning, coordination. However, for response purposes, we're identifying someone or a person or two who will carry responsibility for coordinating response, because that element of the disaster risk management framework comes with its own set of requirements. So what that person or persons will do is to primarily coordinate the psychosocial response. And that means review reports from the psychosocial team and ensure that it is submitted to the Regional Coordination Center, which means that during the response phase, that person could be based within the RCC. And if you remember the RCC that Captain Herwood mentioned, then they're going to organize the teams for deployment. And that means ensuring that they're registered in the database, that their credentials are up to date, contact information, whatever permissions need to be granted prior are granted. So for example, UWI as a regional institution, you as and also as an employer, if we have, say, an Ayodele, pardon me, Ayodele for referring to you by name, who is part of the skills inventory database, willing to be deployed, it is now for internal arrangements between UWI and Ayodele to ensure that the appropriate leave, for example, is granted so that she can fully participate in this kind of response. Coordination issues, for example, over time, you're going to find that issues will emerge and you'll need to fix them. Now, there is a broader CAPSIG, and then there is that specific person within CAPSIG. CAPSIG itself would also need to be updated on what is happening, because again, you would have taken decisions about tools, resources, codes of conduct, that kind of a thing. You also should be assisting CDEMA and the RCC in monitoring and ensuring that all is going according to plan. And also that person will assist and work in collaboration with CDEMA's RTC, the Regional Training Center, in coordinating the annual response trainings. Captain Yearwood did mention that from, say, earlier in the year, say June, May, then they would start their training cycle in readiness for the hurricane season. However, those kinds of timelines may need to be viewed a little differently in the context of psychosocial response. For example, COVID is not a season per se. You may have other traumatic events. For example, Haiti's earthquake occurred in January. You may have a volcanic eruption. So training should be ongoing, even though you may have specific, say, training at particular time of the year, but it's a cycle to allow any team to be deployed within that time frame to be fully prepared and ready. And the response, the psychosocial support response team themselves are the actual persons who will be deployed in the belly of the beast, so to speak. So those are the persons, for example, whom Dr. Ines Springer would have had in her database who expressed a willingness to be deployed. Their role is to participate in trainings, and trainings has been a very topical issue since we started since morning, and to actually deliver the psychosocial support in the theater of operations, all times recognizing that once you're a part of this database, you should be on standby for deployment as necessary. Be familiar with tools and resources that are needed for psychosocial intervention. And again, participate in simulation exercises. So I'm quite happy that a lot of the discussions that have been happening about trade winds exercises, and I know sometimes countries have simulation exercises. Here lies an opportunity for the PSST, the psychosocial team, to be included in those kinds of activities with the assistance of CAPSIG working through the health sector subcommittee. This can be possible. And also, let me not ignore the familiarity with CDEMA's operations and the SOPs, because remember, as a PSST or a member of the psychosocial support team, you are now supporting the regional response mechanism. So you have to be familiar and represent what they stand for. So broader members of CAPSIG, you will do what normal members do. You ensure you are prepared before the meeting, you ensure you participate in meeting discussions, and ensure that you contribute and volunteer to work on special actions. And special actions here does not necessarily mean the response function or being deployed, because what I anticipate is that you actually start working through and become more organized. There is so much work to be done. So you can actually, depending on your specialization, agree to work on specific actions.
So that was module 1 of our training. We're going to give you now a short quiz to test your memory of what Karima said. We'll put the questions on the screen and then we will put the answers up afterwards. So go ahead with your quiz now.
Okay, good afternoon, everyone. I do hope everyone is back because we're ready to begin again. This time I'm going to focus on part C of the codified protocols, which will look specifically at the SOPs for the psychosocial support team. Now, if you recall earlier, we focused on CAPSIG, which is an interagency coordination group proposed to be established at the regional level, which would deal with broad matters of, recovery, preparedness, planning, and even response. So we're actually going to be looking at the procedures that we intend to guide the psychosocial support team, the 6th team of the technical teams of the RRM. And so for this module, what we're going to be looking at are the 6 phases of operation of the team. There are 3, in most of these phases, there are 3 units involved: CDEMA, the PSST coordinator, and the PSST themselves. We're going to be looking at the procedures for each. We're going to be also looking at some of the elements that will constitute the logistical arrangements for the teams. And we're also going to be looking at reporting arrangements for those teams. All right, just to step back a little, and I think Captain Harewood mentioned it, that we're not just dealing with one event or 2. In fact, the Caribbean can be described as a very hazardous region. In fact, the 2nd most disaster-prone region in the world. And so we're going to be always expecting something to happen in the regional landscape. And therefore, this is the basis of the concept for the operations of these SOPs, recognizing that the Caribbean is vulnerable to multiple threats, as you would see here. Recognizing also that these hazards cause severe damages that result in psychological impacts of the affected population and responders, and therefore that impact is going to warrant the provision of psychosocial support to the affected population and responders, and it is also going to require the coordination of organizations and individuals who provide those services to the affected population and responders before, during, and after a disaster event. So typically you will see this as the concept of operations for any of CDEMA's plans, just recognizing that stuff happens, and when it happens, you must be ready to provide that response. Now, you would have seen this diagram from Captain Harewood's presentation. What I've done is to just neatly stick in that 7th team in there, well, except the regional security system, which is not one of the operational teams. Psychosocial support will become the 6th. There's a team missing, or did I count incorrectly? LSAR. Sorry. All right, so we'll get back to that. Okay. And so, as Captain Harewood mentioned, this psychosocial support team will be governed by the same policy frameworks and institutional mechanisms that govern the other teams that he would have mentioned earlier. And of course, the SOPs will therefore be an annex to the regional coordination plan. Now, typically, if you look at any of CDEMA's documents, you will see a 5-phase approach to operations. We're introducing here a phase 0, which is the training phase. And for the other teams, there's a training phase as well, except that it is represented a little differently. So this is tantamount to the same thing, except we're referring to this training phase as a phase 0. Now, phase 0 is a training phase. And herein lies some of the discussions we had earlier. Now, the persons who will go on to be trained will have to be carefully selected and prepared to execute the psychosocial support services in an affected state. And just to pause here, because one of the principles of the Regional Disaster Response Support Doctrine speaks to sovereignty. So teams will not under any circumstances be deployed unless that affected state makes a request for assistance from CDEMA. So we are always in standby mode, no matter how bad the situation seems. Unless a request is made, the team cannot be deployed. And part of the preparation of the team involves training. And we spoke about this earlier, whether we should synchronize training with CDEMA's training cycle, which is usually the most prudent, because now you would have the unit of CDEMA, the regional training center, being involved, so they will have to schedule for particular times of the year. However, the training can be ongoing as indicated, because unlike some of the other teams, we expect that any event that causes psychological trauma or psychological impact could potentially warrant the deployment of the PSST. Now, there are some trainings, of course, that we have to put a timestamp on, just to ensure that persons are current and that that the training is valid. We say 1 year, especially with the SOPs, because you don't want persons forgetting what the procedures are. The seamlessness of the response operations is going to be dependent on how well and how prepared the teams are. So in this phase, we anticipate the following procedures from CDEMA. CDEMA would request a list from the psychosocial support coordinator of possible volunteers to be trained. CDEMA will review the training content and confirm training schedule. Now, again, remember that CAPSIG will be involved in training as well. So if, for example, we feel that, training, and I'm saying we, speaking on behalf of CDEMA, so if CDEMA feels that, and if CAPSIG feels that, teams, the PSST should be fed a diet of particular thematic areas, then the training will be so designed. CDEMA will also plan the logistical arrangements for the training. Of course, everything is now linked to the whole of CDEMA system, so the regional training center, even if it is not the host, but will be involved in the coordination, so as part of its own monitoring and evaluation of what is happening where regional response is concerned. And then the training will be conducted in collaboration with the PSST. Now, again, CDEMA is involved, but it doesn't necessarily mean that CDEMA will be the facilitator of the training. So those are the procedures we expect certainly on an annual basis from CDEMA. The response coordinator would therefore collate the list of volunteers and all the relevant information required by CDEMA and dispatch same to CDEMA. They will also assist CDEMA with planning and logistical arrangements and ensure that appropriate training materials are available and work alongside CDEMA to develop that training schedule. The members of the team who will potentially be deployed will, in response to those procedures from the coordinator, submit the requested information in a timely manner. Might I stress that? Participate fully in all trainings, workshops, or simulation exercises, because simulation exercises are in fact considered training tools where you practice or rehearse what is in the plan. Okay, I'm so sorry, my fire alarm went off just now. All is well. And they will also ensure that CDEMA's criteria for RRM deployment personnel are met, as I mentioned earlier, and Captain here would have intimated at it. There are procedures for deployment of personnel, some of which I think he spoke to in terms of physical wellness and so on. Now, following the training, there's a recommended phase of pre-screening. And I think Dr. Weller and is it Maya introduced this in our discussions earlier. It is recommended that all practitioners that volunteer for duty undergo a pre-screening to determine if they are fit for deployment. We recommend that we do this following the training so that we do not eliminate prior to. Or if it is felt that this phase needs to take place before training, then that shouldn't be a difficulty either. To answer Peter's question, it is recommended that pre-screening is done by a senior, well-experienced, specialized practitioner using some kind of standardized instrument. And again, there are a number of persons involved in psychosocial support. And from what I understand, there are persons who operate at the base of the pyramid who could be somebody like myself trained in psychosocial first aid. And then you have the very well-experienced, trained, and certified practitioners who operate at the top of the pyramid. So it is somebody along those lines with experience who would be involved in the screening process. Now, some of the things you'd want to look for in the volunteers would be persons with pre-existing psychological conditions or medical issues that would make them unfit for duties. Or if you're like me, you break down easily when you see a child suffering, then clearly that kind of a thing would not be for me at all. So those are some of the reasons we would want to screen to ensure that the help that is provided is delivered to the affected population and not the reverse where, you know, a country is impacted and they now have to try to take care of somebody who's supposed to be providing response. All right, so that takes us to the alert and notification phase, which is phase 1. CDEMA, more often through various other mechanisms, whether it's CIMH or the regional seismic research center rather, or any of the volcano observatories, they may receive early warnings that something is looming on the horizon. It is CDEMA's responsibility, therefore, to issue these warnings, whether it is via email or any other appropriate means, to the PSST coordinator. And that it is at that point that the readiness mode begins, because CDEMA is also going to request that these persons be placed, or they at least have a list of persons who can be deployed if the situation warrants. Now, having received those warnings, the coordinator will confirm among its members their availability for deployment and place them on alert. Now, as we would have seen in the skills inventory database, some persons can go at the drop of a hat, some persons may need a little more time. Whatever the case is, the PSST coordinator should have those indications earlier on so that if the need arises, they can readily respond to CDEMA. The coordinator would also ensure that members on that list are already pre-screened and begin to now develop a roster for deployment. Because if something is looming on the horizon, as we would have seen in this hurricane season, some systems rapidly develop, some systems develop and dissipate quickly. So it is always a watch and see, but you should always be ready to go should the situation warrants. Not only that, the coordinator should be confirming tools or reminding the team of the tools and resources and coordination arrangements. Because sometimes we do forget, and if we do not operate according to guidelines, some new tool may be out and trending, but for whatever reason, for example, CAPSIG may have said, no, at this point in time, we are not going to use that tool because of these reasons. It shouldn't be that a team member feels compelled to use it whilst the larger group decided against it. So it is always good to confirm tools and resources that will be used while in the field. During this alert and notification team, the team member must confirm that they have received the alert. Now, in disaster management, and especially during response, communication is absolutely critical. No one is going to assume you received the alert if you have not confirmed. And that is why a lot of times in disaster management, there are a lot of redundancies. So you may get the message in 2 different places, for example. You must at least respond and confirm. It is not automatically assumed that you have received the alert. And that's very, very important. You must also reconfirm your interest in being deployed. Stuff happens that we have no control over, whether it is your own psychological state at this point in time, even though you may have been okay otherwise, family obligations, you're unwell, you know, whatever it is. Say to your team leader, your coordinator, I am confirming or I am not confirming for this mission. And always adopt a readiness mode for deployment. So whatever is on that list, the packing list, for example, make sure it is always at hand. Make sure your passports are always renewed. If you need visas, make sure that those visas are always renewed. If you need insurance, ensure it is always up to date. Whatever it is, you must always adopt a readiness mode when you're a part of this kind of team. So having gone through the alert and notification phase, we now move to the activation phase. This is when CDEMA confirms that, yes, we are going to activate the team. So you're no longer on standby. You have been confirmed for deployment. So what will happen here is that CDEMA will request the activation of the volunteers through this says PSST executive, but it's a coordinator. CDEMA will share information on the event with the PSST, and this is important. When I spoke to Ayodele and Gina, they had a nice fancy psychological term for it, something about sensory perception or something of the sort. You need to place your mind, place yourself in the battlefield. This is what is going to confront me. So as much information as CDEMA has, it should share it, and it usually does. These are standard procedures for the other team as well. And what CDEMA will also do is to implement arrangements for processing the deployment of the PSST. Of course, there are a lot of administrative arrangement that goes into this. Deployment kits and resources through CDEMA, at this point, they should be prepared. And whether or not CAPSIG is also, and any other member is contributing to this deployment kit, those coordination arrangements should be known, those contributions should be known and be included as part of the broader resourcing of the PSST. Hope I'm not losing anybody. If you think I've gone too fast, gone too far ahead, and I'm missing something and you feel you're behind, please feel free to interrupt and ask a question. All right, so continuing on the activation phase, the PSST response coordinator will have the following functions. They must confirm and acknowledge the activation request from CDEMA. Again, they're going to assemble and roster a team based on CDEMA's event brief. Now, the team, the size of the team, the number of persons, and the duration will depend on what information comes in the event brief, and also perhaps the availability of the teams to be deployed. So at that point in time, the PSST coordinator adopts a readiness mode and awaits further instructions, and also continuously reminds PSST members, the team members, of the coordination arrangements, and also the CAPSIG who are now who would be the interagency group consisting of all those members, that this is what we are working towards. Because many times you have agreements, protocols, guidelines for how we will interact and relate and, you know, carry out our mission in the field. And at some point in time, whilst you're in the field, you're going to hear that my headquarters supersedes any agreement by this interagency group, and it creates confusion. That is part of CAPSIG's role in the preparedness phase, to ensure that there's full understanding of what is intended to happen, especially during the response phase. At this point in time, once the team is activated, the psychosocial support team confirms the receipt of the activation request, provides up-to-date contact information to the coordinator. They assembles the packing list, travel documents, whatever PSS materials you're going to use, any resources. So if you have kits for children, kits for teens, if you have presentations that you're going to be delivering to responders to help them through whatever it is, put those together once the activation request is made. And for mobilization and deployment, there's a lot of responsibilities here for CDEMA. They're going to be mobilizing the psychosocial volunteers through their response coordinator, coordinate arrival with the National Disaster Management Mechanism. If the national mechanism delegates, for example, to Ministry of Health, then that must be known and those arrangements coordinated seamlessly. But the team will not arrive unless there's some system mechanism in place to receive them in the affected state. CDEMA should provide all the logistical support and share the travel itinerary and deployment package with the PSST volunteer, who is the point person for coordinating the team. It would be the responsibility of the coordinator to assign team leaders, to brief the deployed teams based on information received from CDEMA. Too much briefing is never enough. I'm going to make the example here of discussion with Red Cross. They were briefing almost at every point until they arrived at their location, their base in the affected country. So day one, when the early warning and alert is issued, you may have gotten a briefing that sounds a lot different from when you're actually ready to be mobilized and deployed. The situation may have changed on the ground, and so continuous update is always very, very important. So phase 4 is when you're actually in the theater of operations in the affected state. CDEMA will continue to support the team. If there are any changes in the logistical arrangements or even in the local response, the coordinator should be notified. And at this phase also, they are going to be receiving the reports from the team and taking decisions accordingly. Because remember at all times that the teams are being deployed in support of CDEMA. So the decision making on certain levels will have to be taken by CDEMA through their regional coordination center. The response coordinator during this phase will actually do the coordination of the team while they're in the field. They will compile summary reports, because now you may have, it could be one, you may have 2 or 3 teams being deployed. Whatever the situation is, there must be those summary reports presented. These must be received and analyzed, because a lot of times reports come, they're just put through without any serious digestion of the contents and looking at, you know, what next needs to be done and so on. They must be received and analyzed, and they must also assist with troubleshooting challenges while the team or teams are in the field. For the psychosocial support team, during this phase, you develop, execute, and update work plans. Because as you go in and you're attached to the national mechanism, you may assess the situation, and what you need to do is to develop work plans to say, this is what I'm going to do, this is how I'm going to approach it, these are the resources I'm going to use. It is not carved in stone, because usually during that response phase, the situation is so fluid. In a matter of minutes, hours, or even days, the situation may change. And that is why at all times you have to assess, reassess where you are and make those updates accordingly. You would need to provide the psychosocial support to the affected communities and responders. Prepare your daily and brief reports with recommendations. And what we find happening as well as part of the improved or strengthened coordination is that you may find that as teams are deployed and as they represent CDEMA, you may have meetings at the National Disaster Office that they will perhaps need to be in attendance to speak to what is happening on the psychosocial front. Or you may have other groups of practitioners who are coordinating independent meetings. You still need to attend those meetings to ensure that the work is integrated in the bigger process. We now see the affected state featuring, because their role during this phase is to receive the volunteer and to help guide their work plan. Because obviously, if you requested assistance, it is for a particular purpose. So you have to know help to guide that work plan and ensure that the response objectives are met by the teams that are coming in. What would need to be done as well, recognizing that the type of intervention that practitioners here bring to the table, it may be necessary to share information on vulnerable groups without compromising any kind of privacy or breach of any protocols that you may have governing, that kind of interaction. The affected state will also assign tasks as needed. So in the morning, they may say, we want you to focus on this community. And in the afternoon, they may say, as the situation changes, we now want you to focus on this area. They will also be able to receive the reports daily and weekly from preferably the PSST coordinator, who would now present a total position and not an individual position. All right, so phase 5, we are almost down to the final phase. So during phase 5 is where you have withdrawal and stand down of the team. Recognizing that the first roster of practitioners could be withdrawn without a total stand down of the team. So CDEMA would issue the stand down order to the PSST based on agreement with the impacted state. So again, the response could be protracted or it could be short, or for whatever reason, sometimes they feel that the situation is becoming too complex, and if you have more teams coming in, they're not able to handle it. They may just say, CDEMA, please stand down your teams. And again, the sovereignty has to be respected. CDEMA will also look into the logistical arrangements for the redeployment of the PSST. Again, they're very experienced with this, having deployed other teams for several other events, as you would have seen in Captain Herwood's presentation. CDEMA should include the PSST in the after action review. And I know after action reviews tend to be held closely to your chest, because sometimes in those discussions, very sensitive information, gets revealed. But regardless, the PSST should be involved And this is one of the challenges I had personally in compiling, for example, the assessment report. There were very, very few AARs available. Some because they weren't conducted and some because they were highly, highly classified events. However, for the purpose of making improvements to the process, there can be two levels to these reports, one that is classified and one perhaps that is declassified. Or more like a lessons learned report, so to speak, so that you can see, where improvements are, because these will now need to be shared again with CAPSIG, so as they deliberate and improve upon, what needs to be done. There's that openness and transparency in the information that they have available to them. So during the withdrawal and stand down phase, the response coordinator, the PSST response coordinator, will compile a final report and submit to CDEMA's RCC and to CAPSIG. They will ensure that the deployed teams are debriefed, which is not to say that they themselves will personally do the debriefing. However, from the CAPSIG pool of experts, those arrangements can be made to have a suitably qualified or experienced person undertake the debriefing. The coordinator should also ensure that all the resources and equipment that were deployed are handed over to CDEMA RCC as necessary. Now, these resources can be anything from sat phones, handheld radios, excess materials that were issued. It could be laptops, whatever it is. Those would have been recorded during deployment, and the coordinator must now ensure that all of them are returned to the CDEMA's RCC as necessary. And they would also notify and stand down all teams who have been placed on standby. Because now, remember, you'd have a roster, and so as one team is in, the other is on standby. If you now need to place, to stand down those teams that were on standby. The psychosocial support team always prepares a final report, hands over to the response coordinator, attends a debriefing session if required, and ensure that he or she hands over all resources and equipment to the response coordinator. So in terms of logistical arrangements, each of these boxes, and I'm counting 1, 2, 3, 4, and 4, about 10 boxes represent all the areas of logistical operations that will have to be considered in the deployment of any team. It is no easy feat, and that is why these procedures are so important, because each unit, and by unit I mean CDEMA, the coordinator, CAPSIG, the PSST, and even the affected state, if they don't do what they're supposed to do, they can represent kinks in any or all of these areas for logistical arrangements. So for example, resources and equipment. The team should be deployed empty-handed. Whatever materials are going to be needed based on the event, the location and type or magnitude. So whether it is PPEs that are warranted, as listen to Captain here would speak about the COVID protocols, for example. How the kinds of interventions that will be delivered by the team, and whether or not any supporting resources and materials may be needed. All of that has to be factored in the logistical arrangement. Then there's communication. We cannot assume, for example, that the normal communication means will be operational. Haiti communication was down, Dominica, BVI. even if it is available, it may be spotty and only available in some parts. So with this information, the appropriate communication equipment will be deployed with the team members. Meals. It is the usual practice of CDEMA to deploy each member of the team with 3 days supplies of meals or ration. This meal I hardly think involves, lobster and any expensive cut of steak or anything. So that has to be borne in mind, that we're going to literally soldier it in the field. Operating base. Now this one is a little tricky. As best as CDEMA can, they will identify an operating base prior to arrival. However, there have been points in time where teams are deployed and they just have to figure it out as they go along. Case in point, Haiti. Once the teams are deployed, they go in, they just have to find somewhere that is safe enough, secure enough, that accessible enough. So be prepared that that may also be a reality for any team going in. Accommodation, again, this may not be 5-star. As best as possible, these will be made prior to deployment. But again, we should expect it to be very basic, given that we're going in a disaster zone. So basic amenities and so on, that's the kind we should, again, that sensory perception that we have based on the briefing should take our minds to that place. Allowance, usually CDEMA deploys teams with a small allowance. Again, this is why the need for CAPSIG to help mobilize resources on behalf of CDEMA is so important, because it takes, for all of what we're discussing here, it is going to take a lot of financial resources. Generally, the financing of the PSST, once you get to the stage where they're deployed and mobilized, it usually indicates that the financing of those arrangements are in order. So CDEMA would actually handle the financing, whether it is seeking funding before from partners and so on. Transportation. CDEMA usually, as part of the logistical arrangements, include transportation to the affected country and the location, or the location base or the accommodation. However, be prepared to get very creative once you're in country to figure out how you will move about. Again, as best as possible, those arrangements are made prior, but given the magnitude and severity, it is not always possible to have a very seamless kind of arrangement. So that is why, and this is another reason why the pre-screening is important, because decision-making skills and so on will need to be brought to bear while you're in the field, because again, we're operating outside of normal mode. Medical. The pre-screening process should help to identify any issues, medical, physical, or mental, that will prevent adequate functioning in the team. However, if you have, say, medications and so on that you need to take with you, ensure that they are in the packing list. There are some countries, for example, that you need certain vaccinations to go to. Those things should be addressed, say, from the preparedness phase and not necessarily as you are ready to be deployed. Although I have seen cases where they are given in the moment, just before deployment. But that's one of the considerations for the preparedness phase, that you examine all of these requirements from across the 19 participating states and ensure that all is in order should a team be deployed into those areas. Insurance is a very tricky area. I'm not sure that CDEMA has, you know, an insurance program for all its volunteers. So at this point in time, the most I'll say is that as an individual, do ensure that you have insurance until such times when CAPSIG begins its deliberation and can perhaps partner with CDEMA and make some arrangements for insurance. But at this point in time, I'm not sure the extent to which those things are covered by CDEMA. So it would be prudent to have, you know, from a personal level, those things in order. So the next thing I'll be looking at is reporting arrangements. And of course, these are suggestions as the PSST takes root, as you begin to think forward on the mandate, what is required. Some of these things, they you know, may look a little different. But in terms of standard reporting requirements, there's always the need for the date of the event. It is almost like a unique code because we have experienced, say, within the Caribbean, several events that occur back to back. Irma and Maria, we have had Lily and Isidore, we have had Charlie and Ivan in very close succession, and there are others. So always try it, and sometimes, to be honest, it is very fuzzy as to where the impact from one starts and the other ends, but the date of the event is always very important. Date and time of the report. Again, you should be able to track in terms of timeline what has happened and what needs to be happening. Who is making the report? What impacts you observed? Because, for example, once the response has died down, and let us say CAPSIG is reviewing all of these, you may find that you may put forward a position to say, for this type of impact, perhaps the next time around, we need to be doing things this way. For this group that was affected, couldn't we put something together, you know, looking like this, maybe a new activity, you know? So the description of the impact is always important. And if you can narrow it down to the particular vulnerable group, it is important for a number of reasons. You need to respond differently to the various groups. But as you begin to formulate your project concepts and your request for funding and so on, you may approach one particular funding organization to treat with the issue of women or gender. You may treat with the issue of disabled population differently, the issue of children differently. And so in those requests, you always want to have data to back up, to justify, provide the rationale for the request. And not only that, this will also help you in your vulnerability assessment phase. And if you want to take it further to a risk assessment phase, the actual impact is usually the baseline position for a lot of these assessments. So it is always good to, you know, make a distinction between the impacts on the various groups. Also describe the number and types of interventions provided, where, for example, the service was delivered. And again, when you are working in a disaster zone, you may find that you have to get very, very creative. Sometimes it is under a tree. Sometimes you find that you have to deliver it in a shelter. Sometimes it's in the police station, in their, you know, lunchroom or something. That will help you to plan for future interventions. And to also perhaps examine, you know, what perhaps the mindset of the persons would have been given this location. So if you're in a shelter, for example, how much privacy do you have? You to explain all that is happening to you. If you're a very private person like me, you may not want to speak up because somebody close by could be hearing and so on. Again, you'd want to look at who is doing what, who is involved with I can tell you that this bit of information was rather very useful as I did the assessment. There are some reports that were done that looked at who were involved on the ground and what were they doing. You may also want to just look at the team composition, what duties they have been assigned, and who the team members are. If you understand and know what is happening from the national perspective, you can say what these are and how your work fits into that, what you intend to do for the afternoon or the following day and so on, and any challenges and recommendations, because now you would have the benefit of your coordinator and CDEMA actually providing assistance in troubleshooting challenges you have, or looking at your recommendations and say, okay, well, why don't you try this as well? Because that's the benefit of having somebody external supporting you whilst you're in the belly of the beast, so to speak. Some things are not as apparent as somebody from the outside looking in. And so that is why the reports need to be very, very comprehensive. I think I am just about coming up to the end of the presentation. So the reporting arrangements, at minimum, usually what you would require to be submitted to CDEMA and to CAPSID would be the situation report. Now, again, at minimum, daily until the standard down order is given. Now, the situation is unfolding very, very rapidly. There may be a requirement to submit, say, every 4 or 5 hours, every 6 hours. But at minimum, daily report should be prepared. Final mission report, at the end of every deployment, there should be a final report prepared. And the AAR, of course, usually comes a little time after, but still soon enough so that everybody's memory is still active. So usually after the stand down is given, a little while after, there's an AAR. Of course, the PSST should be involved in this.
So that is the end of module 2. And of course, you know that we have a little quiz for you as well. So we will put up a scenario and then we will ask some questions based on that scenario. Go ahead now. So that brings us to the end of our training workshop on the codified protocols for integrating psychosocial support into the regional response mechanism for the CARICOM area. We hope you found this useful.